everybody. I'm going to talk about MR arteriogram, venogram. First of all, I have to show you what is a arteriogram, traditional arteriogram and venogram without MRI. Then I can show you what is the MR arteriogram and venogram look like. Traditionally, doctors access the right femoral artery through a needle puncture, put a catheter through the right side femoral artery and course through the catheter through the aortic arch and try to select the left or right side common carotid artery or subclavian artery to find the interesting vessel they want to study. Because of different patients have different anatomy, sometimes quite difficult to get to the correct arch. To get to the correct place takes some time and could have rupture some of the plaques, atheromatoous plaque that age build us, that could cause emboli to the rest of the body. There's some risk, some bleeding risk. For example, puncture of the artery can cause bleeding and aneurysm or hematoma, basically blood clot that you feel a lump in your groin. So that's the risk. So it's an invasive procedure. Unless it's absolutely necessary, we usually do not resort to this kind of procedure, but it does offer good information. For example, this person had a study that this doctor put the patient under the camera and the x-ray shooting from below, receive up here, and the injected dye, which is x-ray dye containing iodine, that is seen on the monitor as this black line, which is the shadow of the artery or vein, whatever we want to study, and that is called arteriogram. And for example, this patient, this is eye, the whole head looking at us. This person have a stroke, and then the doctor injected dye and find out there's supposed to be a vessel, a middle cerebral artery that's supplying most of the brain, and out of sudden it's cut off here. There's something blocking it, that is a thrombus. The patient have acute stroke, cannot talk. So patient went in there, did something. Here's a catheter, get in there, and then did some, there's a variety of devices that to take the clot out. For example, this one is taking this clot out, and then you can kind of see some vessel go beyond the occluded area. So now there's the ischemic part of the brain that's needing blood. Now it's getting some blood flow, and keep taking the blood clot out, is all restored, and patients start talking on the table. So wasn't talking before put on the angiogram to the table. Now after the thrombolysis, basically cutting out, destroy the blood clot, the patient start talking because the brain is getting reperfused with blood and become alive again. Otherwise, if you don't do this, and that's called a stroke, and then the brain is permanently damaged and irreversible. You just permanently lost those function, especially if you're older adult. The brain doesn't have much regeneration capabilities. And that doesn't mean this patient would not have stroke again. Whatever caused the first stroke still have the increased patient's risk, but at least now it's a good success. Here is a MRI arteriogram and venogram together. This combined picture. So it's quite busy, a lot of vessels. Patient is looking at us, patient's left ear, right ear, the eye was not shown, all the blood vessels are shown here. For example, here you can see the first picture is the blood come into the artery. You can see the left side and the right side of the artery supplying the brain, the big one. The smaller one are the posterior fossa. They also supply the brain, mostly the cerebellum and occipital region, vision area. So anyways, it looks pretty good. And then next picture is getting more blood contrast. By the way, this is not traditional angiogram using iodine based contrast. This is MRI contrast, which is doesn't have much allergic reaction to the contrast, and pretty safe. Of course, we have to check the patient's renal function. If patient's in renal failure, GFR less than 30, we cannot give that because of the nephrogenic systemic fibrosis risk. but most of the time we can give this, and then we see the artery well, and then keep going. Now it's the later phase. Basically, you inject, the artery is opacified, and then go through the capillary phase, and then they move to the venous phase, and then go back to the heart. And now you see partially some of the veins showing up already. The internal jugular veins are starting to flow back to the heart. The artery is still pretty bright. And keep going, and then now some more vein opacified. The artery is still pretty bright, but eventually will peter out and doesn't have as much brightness as we are showing here. Now the vein is shown is more bright, and the artery is still bright. Ideally, we could just separate them out, but somehow when we inject the contrast, it's hard to opacify only the vein or only the artery. So sometimes you get the contamination from the other side. Means the other side means artery gets contamination from the venous side, or venous from contamination from the arterial side. This is a patient that we did a 3D volume rendering. Basically, we did an MRI, MR venogram, and then from the information we can use computer to reconstruct the surface. I can window out, take out the soft tissue, and can see some of the veins. You can half see the brain, and then take the face out. Now is the vein show up. Some arteries still show up, but where we're studying the dural venous sinus. So this is the dural venous sinus, the superior sagittal sinus, the internal cerebral vein, the straight sinus, venum galen, sigmoid sinus. I'll show you more. This is what we usually deal with, the black and white color picture, and then we can rotate it to find out which vein is occluded, which vein is patent. It's a good anatomy study. This is artery, MR angiogram of the arterial system. This is the anterior circulation. This patient has a left side ophthalmic artery aneurysm. Aneurysm can be ruptured, especially when they're larger. So we have to watch this, and if it's big enough, we have to treat it either by surgery or putting a coil blocking it from the inside. So basically, we can see the internal carotid artery and the middle cerebral artery, anterior cerebral artery, supplying different part of the brain, and some ophthalmic artery on each side supplying the eye. This patient has a pulsatile exophthalmos. Basically, you can put a stethoscope over the eye, you can hear the pulsating mass in the eye, and the eye is bulging out. This patient has a so-called carotid cavernous fistula. So basically, the artery is bleeding, and bleeding right into a next door vein, and the vein is pretty much not used to handle that much blood flow that fast from arterial side. So the vein is getting dilated, and then the vein also arterialized, and then they pulsating the entire eyeball. And then you can use stethoscopes to listen to it. And then this is an angiogram that later put a coil in there and then stop the arterial blood flow to the vein. This is an MRI study showing basically this is a CAT scan, this is a nose, this is the back, this is the right side, this is the left side. We're cutting the patient's head, tip of the head is inside the screen, and the foot is towards us. Basically ICA is showing the fistula is here. The artery is flying through this little neck into the vein, and the vein is draining towards the eye, which is here. This is angiogram. The nose is this way. The patient looking that way, and that area, the artery is so prominent as compared to the other side because so much blood flow to the area. So this is the orientation. This patient have a big eye, and then the doctor concerned that there was a carotid cavernous fistula, and then turned out this patient does not have it, just because of a big meningioma. This part of the bone is too big, and this part of the soft tissue is too big, because there's a meningioma here. And this is the normal side, the thin bone, not much soft tissue compressing on the optic nerve and the whole eyeball. This is normal optic nerve, and then this is an optic nerve that was displaced away from this mass, and the patient have a big eye, and then and I guess maybe it's a little bit pulsatile, but this is a mimic of a carotid cavernous fistula.